Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to Voices of Otolaryngology. Thrilled to be here with Dr. Doug Ray. The coolest part of my job is making new friends. So what I just found out is Dr. Ray and I have tons of professional admiration for Dr. Stacey Gray.
That's right.
So let's pound out Stacey. If you're listening to this, first of all, you better listen. If you're not, that's your problem. But anybody who knows Dr. Gray, Stacey Gray Texture, he did his fellowship, I guess a year after her at Mass Eye.
Yeah, so Stacey was 9 months pregnant when I came for my interview at Mass Eye.
Yeah.
And she took me around and showed me everything. And then I think she delivered her daughter, Catherine, like 2 days later.
And before then, you were at Oregon.
I was at Oregon Health Science, yep.
Med School, Rochester, Oregon, then Mass Eye, then Hopkins.
Right. Yep.
Yeah, it's not a great pedigree.
I dragged my wife and kids all over the place.
You did?
Yeah, well, I dragged them from Rochester to Portland to Boston to Baltimore.
In 2 years, probably, I think.
Yeah.
It might be 26 months or something.
Yeah.
That's great. And now you've stayed in Baltimore.
Yep.
Okay.
Drive my wife kicking and screaming to Baltimore, but she actually likes it there now.
Doug's fantastic, Dr. Ray. I've gotten the pleasure of knowing him over OPPS and his practice in Baltimore. I live in the Rockville, Maryland area. We could make this whole episode how cool Stacey is.
We could.
Can I give you a cool Stacey story?
Yeah.
So Children's Boston, we all rotate through there. All the Boston programs spend 3 months there, and we would all cover call for each other and rotate with each other. You know how good someone is when they sign out. Right. When Stacey signed out, I mean, I could just sleep because she tucked in all her patients. Everything was perfect. Yeah. So tons of professional respect for her. What's your favorite Stacey story?
Oh, I guess it was the interview story, but
9 months pregnant.
But she was always, I've known Stacey. We were so close in finishing fellowship together. She's always been a great resource, a great friend. I would call her, she'd be in clinic. We'd do a Zoom call and she'd always help me out with stuff.
Stacey, we do have these podcasts sponsored, so you can sponsor it, Stacey. Why don't you be the first individual sponsor, Dr. Gray?
Doug and Rahul, sponsored by Stacey Gray.
Yeah, there you go.
And then I have to do a shout out to my mentor, Ralph Metzen, who was our mentor.
For many of us in Boston.
An absolutely incredible human being and a real
thanks for that, Doug.
So.
We do talk about the shoulders of giants we stand on, and Dr. Metzen is one that we all stand on. So props to Ralph. You can go ahead and sponsor it too.
One of the best human beings I've ever met, known, and trained with.
Well, right on. Well, this is a perfect segue because we're here at OTO Forum, and you led a terrific panel on subspecialty in private practice. We actually have been talking about two of your great mentors, and you have many in your career at the Mass Eye. So you did a fellowship in rhinology.
That's right.
But now you're in private practice.
Correct. So
talk to us about your panel, the audience reaction. Just go ahead and tell us about subspecialty in private practice. What does that mean?
Well, so I kind of made a joke at the beginning of the panel, and I said, I'm a recovering academic. So I spent 10 wonderful years at Johns Hopkins as their rhinologist and skull-based surgeon. I was actually the program director there for 4 years. Cool. So that was a wonderful experience, but I think we all get to those crossroads in life where you sort of have to make a decision, what are you going to do next? And I think the normal course for me would be to find some leadership positions in academics. And I really started to, it used to gnaw at me a little bit that I kind of wanted to have more control over my life. And my dad, when I grew up, he was a businessman, and he started and ran his own business. He was very entrepreneurial. And even though I am a doctor and decided not to follow in his footsteps and work in his business, I always have kind of an entrepreneurial kind of way about approaching things, and I get excited about that. And so I really made a huge turn, 180 degree, into private practice. And I joined my now partner, Mark Dubin, who preceded me at Hopkins. Yeah. Except Mark lasted 6 months there and I lasted 10 years.
Yeah, we'll leave it at that. We'll leave the judgment
exactly.
to that. So you joined your group, which is now under the umbrella of ENT Specialty Partners, ESP.
Yep, that's right. ESP Caden is our large group run by Ron Coopersmith, who you know well.
Yeah, of course.
But when I joined Mark and his practice in 2018, we had just merged with 17 other practices in the Mid-Atlantic to form Caden, which is the Centers for Advanced ENT Care, which was a large group practice. And then in our journey, we tried to create an MSO, which is, as you know, a huge struggle. And so eventually Mark started to talk to Ron, and Ron had done some amazing work with ESP in Texas and created what we wanted to create for Caden, which is a true MSO. in the sense that they handle everything. Compliance, revenue cycle management, billing, HR, everything. And so IT. And so we merged, Cadent and ESP merged. We were probably two similar sized groups. And now at this point, we have probably over 80 doctors.
So did that give the genesis of subspecialty in private practice, or has this always been on your mind?
Well, so
or are you seeing it nationally? How did this panel come about?
Yeah, so I mean, it was my partner, Annette Pham, who asked me to do it, but there are a lot of private practice subspecialists.
Okay, define that and talk about that.
Okay,
just use that as a word.
Right. So we know that within otolaryngology, there are different subspecialties. We have pediatrics, rhinology and skull base. We have head and neck. We have neurotology. We have facial plastics. We have sleep. Did I miss any?
Nope, keep going. This is great.
And so most of us, traditionally, when we did a fellowship, would do it because we wanted to go into academic medicine. Because in the world of academia, you sort of need to be a subspecialist to sort of survive and thrive in that world.
Yeah.
But with time, these academic jobs are full and people are still doing fellowships. And so they're going out into our community and becoming private practice doctors and trying to be a subspecialist within a private practice group. And so that poses very unique challenges to us as subspecialists. And so the idea of the panel was, we're going to talk to the members of OPPS, who are by and large private practice doctors, about how you can be a subspecialist in private practice.
So you can.
You can do it and you can thrive and survive, but there are tricks to it.
So let's talk about them.
Okay. So some of the things that we talked about in the panel is how to find the right practice.
Good point. Yeah.
Right.
You can't go into an underserved area and say, I want to be quaternary.
You can't go into be the only doctor in a 500-mile radius.
So build on that. So, yeah.
So I joined my practice in 2018, as I had mentioned, and within that practice, there were 6 partners. I was an associate, and there was another rhinologist, Mark Dubin. We have a facial plastics doctor. We have have an otologist, and then we have some general practice doctors. So within that practice, it was sort of understood that you could subspecialize, but at the same time, you have to carry your weight within the practice, right? As private practice doctors, we have to pay our overhead. You have to be generate enough revenue to support your existence within the practice. So I couldn't go in and say, well, I could have gone in and said, I'm only going to see rhinology patients, just like I did at Johns Hopkins for 10 years. And I would have not been able to pay my rent. So as a new part of this practice, I had done a tonsillectomy in 10 years. I was doing tubes and tonsils and adenoids, and it was fun for me to kind of relearn these things. But I had to have the expectation that I am a 5-day-a-week clinician, and I'm doing general ENT with the idea to build my rhinology practice. Now, you think that having been at Hopkins and practicing in Baltimore County for 10 years,
would follow you, right?
And I had developed a very good referral
Absolutely, you have a
network.
great reputation. Yes.
But I still had to build. And I would say when I first started in private practice, I was about 50 to 60% rhinology, 40% general. And over time, and this is another question people ask, is how long does it take to build this? And it depends. But within my practice, I would say it took me a good 5 years of hard work, sort of expanding my referral network, to create a practice where I'm pretty happy. And it's about 80% rhinology and about 20%.
So one of your partners, Dr. Dubin, told me you're just a little bit slow sometimes. So the average doc, maybe 2 years. No, I'm just kidding.
Exactly. No.
Dubin wanted that.
Dubin would say that.
Yeah.
Dubin would
so
say
it
that.
took 5 years. Say that again. Very important stat. You started 60% of your subspecialty rhinology, 40% comprehensive otolaryngology.
Correct.
Took 5 years to get to an 80-20.
Yeah.
And where are you now? 80-20?
80-20.
Why not 100?
Yeah,
Yeah. Talk about that.
I mean, I like it when a patient comes in that I've been taking care of for 5 years to get their ears cleaned, catch up with them. And some of I get a lot of referrals from from PCPs, from allergists. They don't want to hear from me that I can't take those kids' tonsils out, or I can't clean those ears, right? They don't want to deal with that. And so I'm happy to do that. And they also know that if they have a complex sinus patient or anything else, they're going to send them to me.
So you were on this panel, you've given this a lot of thought nationally, and you have the expertise of the ENT Specialty Partners, ESP. When there's subspecialty in private practice, what are you seeing out there? Are most content with 80-20? Are most 90-10 or completely 100%? Or are most 60-40? What do you see out there? once they're mature.
Yeah. There's a huge disparity. So I had Doug Backus on my panel. He's a neuro-otologist who practices in Seattle. He is 100% neuro-otologist.
Okay, there you go. Okay.
He is like an academic neuro-otologist in private practice.
So no tonsils for Doug.
Correct.
Okay.
And if he gets a sinus patient, he sends them to one of his partners, who actually is a good friend of mine, Greg Davis. And so then there's other doctors that we talk to who are subspecialized who do see a fair amount of general. And I think it's very variable in terms of where you're practicing and how you're starting, right? I think if I had tried to go right from fellowship into a practice without having been at Hopkins for 10 years, I would have probably started at 25% rhinology.
Really?
Well, it depends. And the other thing is that I had mentioned when we talked is that in my group, in our division within KESP, we have 6 partners and 1 associate. They're all very good sinus surgeons. I'm not going to tell my partners to send their sinus cases. They'll run things by me in a clinic. They'll show me a CT. How would you approach this? And for really hard, like an inverted papilloma or something, they'll send them to me. But for the most part, I don't get a lot of internal referrals. Now that being said, at Hopkins, I trained a lot of fellows that went out into the communities and didn't necessarily go into academics. Some of them entered in large group practices where you had 10 or 15 doctors, and they were happy to send their sinus cases to that person. And so I think it's a caveat for every fellowship trained otolaryngologist who's trying to figure out what they want to do and what their practice is going to look at, to sort of have their eyes wide open. So, and those are good questions to ask. Are you going to refer your sinus patients to me internally, or is it something I'm just going to have to build, and that'll set the expectation, right? I'm going to have to be a general comprehensive otolaryngologist to start with, and then build through my referral network.
Terrific. Go back to what you said. If you came right out of the eye and ear for fellowship, terrific fellowship program, and you went into private practice with a subspecialty focus, you thought you'd only do 25% of your rhinology. Why?
Well, because
I thought it'd be 90%.
Well, I was a Hopkins rhinologist for 10 years. Now, I could have, so that sort of built it up for me.
That's what you're saying. You have to build a practice. Yeah,
what you're saying is if
you went right out of the eye and ear into private practice, only 25%.
Well, it depends, right?
Yeah.
I would have had to
build it up.
Or I could have found a group. I think most of the residents that are graduating today know how to do sinus surgery. And they have really good training in their residency program by fellowship trained rhinologists. And so they know how to do it. But 20 years ago, that wasn't the case.
Absolutely.
And so you could go into a group with some older comprehensive otolaryngologists who say, like, and then you can do my sinus cases. Yeah. And so it depends on where you're going and the group that you're entering into. And then how saturated is it? I mean, I practice. How saturated is the market?
Saturated is the market. Okay.
So, the Mid-Atlantic, Baltimore, the Baltimore, DC area, highly saturated with rhinologists. It's the same thing with facial plastics, right? I mean, you can go and hang a shingle up and say, I'm a facial plastic surgeon right out of fellowship, but how busy are you going to be if you don't do comprehensive ENT?
So let's do a few case scenarios. It's incredibly helpful. So our audience, let's say, I'll present you the scenarios because I think I've got it in my head. You come out of an excellent, strong residency. You don't feel the need to do fellowship. You want to go right into private practice, but you have a passion for X, Y, or Z. They can do it. You can build a subspecialty private practice without a fellowship.
100%.
Can you talk a little bit about that?
Well, one of the things we talked about is what are the advantages of subspecializing? Why? And we're all different. Some people like to do everything, and they want to do thyroids, they want to do parathyroids, they want to do a little bit of head and neck, a little bit of peds. And I have 2 wonderful partners, and that's what they do, and they're very good at it, and they love it. And then there are other people like me who like to be an expert in something, like really good at 1 or 2 things. And so I really wanted to be a rhinologist and an endoscopic skull-base surgeon. And I don't actually do a lot of skull-base surgery anymore because I'm in private practice. I work at a community hospital. We don't have a neuro ICU. I don't have an experienced endoscopic neurosurgeon to work with. So I've happily moved that part of my practice back to the capable rhinologists at Hopkins to do those cases.
So someone coming out of a strong residency wants to join a private practice And what do they look for if they say, I want to do subspecialty focus, I want to build this up, or I want to be comprehensive? How do they what are they thinking? What do you advise the next generation?
Well, I would say if you really have an interest in rhinology, you should, first of all, in your training, spend that extra little time. I think most residency training programs, I know at Hopkins, we did a pretty good job of allowing the residents to within the residency find ways to get extra time with,
and whether that's otology, head and neck, whatever
you want to do. So get that extra time. We just hired an associate who just finished her residency training at Hopkins, Melissa Liu. She's a wonderful young associate that just started with us a couple of months ago. She has an interest in otology.
Can she sponsor this podcast? It could be Ralph, Melissa, Stacy.
I don't think
they could divide it. She just started.
A new associate.
All right, fine. We're going to go back to Boston.
Exactly.
Right.
We'll do Ralph and Stacy can handle this. So she has an interest in otology.
Yes.
One of our partners is Brian Kaplan, is the chief medical officer at Cochlear, does a lot of cochlear implants in our community. So she's starting to do cochlear implants. She's going to do a little bit more complex otology. Is she going to do acoustics? Of course.
Right, so perfect example. She's joining you. What % of her practice will be otology to start with? Maybe 50, 60.
Oh, no. I think she'll 10, 15%. Wow. But I'm happy to send her any.
Right. So she's got to build it up is what you're taking.
I find her too bad. I mean, perforations, I'm not going to fix those.
Right. But so you can't walk in there and just expect it's going to be there.
I think you have to have really.
I mean, here she is coming in.
And she's happy to do everything.
Of course. That's your point.
And that's the point, is if you can do whatever, you can make your practice into whatever you want it to be, but you have to be realistic about it. And when you're in private practice, there are expectations, whether you're working for a hospital system or you're physician owned. You have to carry your weight and you have to be a good partner, and whatever that means in your partnership. And so those are questions that you should be answering before you take a job.
Someone like Doug Backus can do it. Brand recognition. He was in academics for, I think, 17 years, right? A neurotologist.
And then he practiced at practiced at Virginia Mason. He was subspecialist at the start.
Yeah, he had the relationships, just like you said.
But I would say that that's the exception.
Absolutely, absolutely. What other big issues came up in your panel that you'd like to share on the Voices of Otolaryngology with our members?
I think that we had Kevin Watson, who's a CEO of one of the big groups in Raleigh, and he's part of Ascent, and so he's got a good business sense. And he talked about if you're running a practice and you have subspecialists, there are certain subspecialties we know that are much more profitable than some others. Like, so you look at facial plastics and rhinology as compared to pediatrics. So he said that they've adjusted their comp formulas a little bit, so that part of theirs is a shared model.
Interesting.
So that the people that are in the trenches seeing the pediatric, doing a lot of pediatrics,
60 kids a day,
and then the rhinologists who are making a lot more money in terms of their billings.
Wow.
It's a little bit of that shared. And so again, every practice is different, and it's sort of the partners sort of coming together and figuring out what works. I think we have a very fair practice. We sort of kill what we eat, and we have a shared overhead. I pay probably a little bit more overhead, but we're all sort of in it together, and we all have a sort of a fair model, but every model is different.
So that's interesting that Kevin noted that, to make it somewhat equitable, because you want to take care of the community, right? You don't want to bleed those patients out or lose them.
Yeah, we know academic institutions face the same issues.
Yeah. What else came up in the panel that you found an interesting kind of an aha moment on subspecialty in private practice?
I think Doug Backus had a lot of sort of interesting sort of tidbits to share about his long journey, and he keeps all his referring doctors on his cell phone, and he puts notes in there about whose birthday his child is going to Brown University, it's his birthday on this date, and he communicates and sends them messages, and sort of it's like his family. And I think having a good relationship with your referring physicians, having being close to them, being responsive, I think that is really important, whether you're a subspecialized otolaryngologist or a comprehensive otolaryngologist.
That's fascinating, even more so in a subspecialty practice. Yes. Talk about that, yeah.
Well, so, I get a lot of referrals from primary care doctors that know that I'm interested in rhinology. But,
yes.
So I get a lot of referrals, and I will call them about complicated patients and be responsive to them. But I also have other otolaryngologists within our region who have referred patients to me for years of complex sinus patients. What I've always made it clear is I'm not trying to steal anybody's rhinology patients. We can all do rhinologic surgery for the most part. We're all well trained to do it. But what I'll do is provide myself as a resource. So and I'll tell them when we meet, hey, if you have a weird CT or like a weird case that you just want to get my advice as to how to handle it, just call me. And I get calls all the time about, hey, how would you do this? How would you do that? Most of the time, after I give them an answer, they take care of it. Sometimes I say, you know what? That's a little weird.
These are referring docs, or these are referring otolaryngologists?
Referring otolaryngologists. So sometimes I'll say, you know what? Maybe you should have me take a look. And so I try to be a resource rather than a competitor.
That's wonderful, right? So you work together.
Exactly.
Did the continuing education come up? So subspecialty, private practice. Let's not talk about you. Let's talk about what you heard out there. Otologist, laryngology, peds. How do they balance their continuing education? I mean, you've still got to learn guidelines. You have to learn a lot. You're 60-40. How do you keep up on everything? It's hard.
It is hard.
Right? And you have an excellent reputation over both. So you are, investing in yourself.
I mean, I try to stay well-read and current on the literature. I will say, even within the AAO-ANO, when I'm doing my recertification
what are you? Which track are you on?
I'm on the, no, you're going to challenge. I have to take an exam every 3 months. And
but are you on a subspecialty?
Oh yeah, so I'm on the allergy and rhinology track.
So I'm a otolaryngologist.
Yeah.
What track am I on? What do you think? What MSc?
Comprehensive.
Yes, sir. Because I love it.
Yeah.
And I don't mind. I think I mean Brian used to might get upset.
How are your scores?
I know you're gonna say that. I think I'm like 83%, but I don't
think that's pretty good.
I know, thanks.
I mean, I think I'm only 89% in rhinology.
But what I love about it is I'm learning. Oh, I didn't know that about allergy. Oh, that's an interesting thing about. So that's why I do it. So your MOC you do on the rhinology.
For my MOC, I do rhinology now.
So then how do you keep up on your general comprehensive?
I try to stay well read, and I pit my partners a lot. If I see something that I haven't seen before and I'm not quite sure,
current treatment,
I'll text them or call them on a weekly basis. I ask them, and my partners are very bright and well read, and they'll give me good answers about how I should approach this patient, this comprehensive.
Let's flip it as we start wrapping up. Let's flip it. We talked about what's good with subspecialty and private practice. What worries you with your group, Cadent, ESP? What worries you that you heard about the panel? I think one thing that Kevin Watson talked about was the compensation model. So it depends how big your practice is. You need to balance a compensation model. You yourself mentioned overhead. You pay a little bit more overhead. I presume that's because of the rhinology subspecialization. What other things do people need to think about?
So, I think as an academy, we have to think about fellowship training. And so I, during the lecture, had AJ Tompkins stand up because I'm on his.
So I call him AJ Workforce Tompkins.
He is the man.
So you're on his workforce too?
Yes, I am.
So is David Yen. Everyone who sits here is on his workforce. How big is his workforce? It's actually small. There's only like 7, 8 of you. Yeah, I'm just kidding around.
He handpicks.
Yeah. All right, tell me.
Because he needs people that'll
do the work.
Yeah. So if you haven't read in one of the
amazing. Go ahead and sell it. Go ahead.
Yeah. What I said to the audience is, if you haven't read the Academy socioeconomic and workforce survey, you need to, because it is just chock full of useful information in all areas of otolaryngology and what we're practicing.
And it's actually over 100 pages, but you can flip through, look at the diagrams. It's awesome.
100%. Yeah. And so one of the sections I wrote was on fellowship training. And so one of the things that we brought up is, do you need a fellowship to practice? And there's a big disparity amongst subspecialties about whether you actually need that extra level of training in private practice. Mm-hmm. I mean, I think we all understand that if you're going into practice in an academic institution, it's in your best interest to do a fellowship, because that's how you're going to survive and thrive in that environment. But in private practice, it's a little bit murkier. It's a little bit gray. And so it's clear that with neuro-otology, if you're going to do complex neuro-otology in your practice, you really need a fellowship. And
absolutely.
Most of the respondents who were in private practice said they use a lot of their fellowship to be able to compete and survive in their practice and practice. And so in rhinology, it's a little bit less clear. With rhinologists, a large majority of the respondents in private practice said, I learned enough in residency to be able to do rhinology, most of my rhinologic cases in the residency training I got.
Interesting.
So then the question is a fellowship useful if you're going into private practice? And you brought that up before. Like, can't you just go into get good training in residency and just say, I'm going to be a rhinologist? And the answer is yes. We don't have a board certification or anything else. And so I think, and because the academic jobs are few and far between, more and more fellows are going into private practice, both from facial plastics, rhinology, and other areas. And so then the question is, are we adding value by having them do a fellowship? Like, what are they getting out of this? And so maybe they didn't feel like they got
exactly
good enough training.
It's a comfort level, right? It's not a value judgment.
And that's 100% a good reason to do a
Exactly.
fellowship. But if you're competent and you feel competent and you're just doing a fellowship just to say that you did a fellowship and you're going into private practice, it's not clear cut that you're going to have a benefit from just saying I'm a fellowship trained rhinologist in private practice if you already were competent before you went into your fellowship.
Extremely well said. For our listeners who now we have thousands, almost tens of thousands of listeners, thank you all very much. And again, thank you, Ralph and Stacy, for sponsoring this episode. If you don't know, you've actually sponsored it.
He's going to send you the bill.
Oh yeah, for sure. There's a URL or link which our team, Miguel Ventura and Chris Harris, Jackie Cole, put on this, which will link you to the workforce survey. So whenever we talk about materials, we link them right to it, just so you know that. Let's spend maybe the tail end of this. What does the future look like? You and I both did fellowships. We both entered into academic practices. We took different routes. What does the future look like? What do you see out there? Do you see more of this? I think you're convincing me that I do. I see a lot more of this, subspecialty in private practice. Okay. What do you see as the future? Do you see less subspecialty in private practice, more? I think a lot more.
I do too. And
a good thing. It's not a bad thing.
It's a great thing. But the thing
if
about
it's 60-40, right? I mean, very rare is it going to be 95-5, 100-0.
I think being subspecialized can help us to be experts as well. But it's the most important thing is, and this is the world of private practice, we need to be able to take care of all problems, right? Like we can't be siloed into just our subspecialty, and especially in the world of private practice. So I think one of the critical things that we need to do is when we're training our fellows how to do our subspecialty, we also have to train them, especially if they're going to private practice, what private practice the world looks like. So most of us who came from academics didn't really understand what private practice looks like. And I think sometimes our residents aren't exposed to enough private practice during their training and what the private practice world looks like.
Can I interrupt you?
Yeah.
You're absolutely right. And Doug Backus, we've talked about him. He actually said that at dinner the other night. He said, I went from an academic to private practice, and he said, I had no idea.
Right. And so I think a lot of residency programs are starting to recognize that they need to teach their residents about private practice.
Yeah.
And so what that world looks like. And so same thing with our fellows. But yes, you're going to be subspecialized, but you're going into private practice. And you need to understand that this is how it works. And you need to be able to do comprehensive otolaryngology.
Interesting. Yes.
You need to understand business of medicine.
Yes.
You need to understand what different practice models look like. Are you going to be working for a health
almost
system?
Double the work, Doug. So do you see it getting bigger in the future? 5 to 10 years from now, you're going to see more of this?
I think what we're going to see is that residency and fellowship training programs are going to have to change to meet that need. And I already see it. I see it in the lectures. Last fall, there was a huge academy lecture and panel just on residency training and
Crucial Conversations, Part 2, Al-Maradi et al. Yeah.
And so
talk about that. Go ahead.
Well, it was just a conversation about what we're teaching people in residency and where we lack and where we're falling short. And I think one of the obvious areas is private practice, business of medicine type of learning.
Any other pearls? So I like to have fun with this. I'm going to give you some fun questions at the end, but anything else you want to drive home? A lot of pearls. We have a lot of respect for you. The panel was awesome. Anything you want to conclude with?
Well, I just think do what you love, find people you want to work with, be inspired by your job. I used to tell the residents all the time, and to me, the thing that I miss about having left Hopkins are the residents and teaching. And I still get to work with them at my community hospital, thankfully. But it's so wonderful to work with them. But I always used to tell the residents, if you're not learning, you're dying. And you need to always grow and change the way, find new ways to change your practice. Ask people like, why do you do that? Or and the residents come to my OR all the time, and I say, well, how does Nick Rowan do that? Or how does so-and-so do that? Like, do they do it differently than me? And why do they do it? I might just try that. Like, I love to change the way I'm doing things. Practice now, the way that I operate, the way I approach patients is totally different than it was 10 years ago.
Yeah.
And I think just learning and growing, it's sort of the human process. And so we as otolaryngologists have to sort of grow and develop, and don't be afraid to take a risk out there. I'll just say that leaving Hopkins and going into private practice was one of the biggest risks that I ever took. I didn't sleep for 9 months before I did it, and I didn't sleep well for 9 months after I did it. It ended up being, I think, next to marrying my wife, one of the best decisions I've ever made. Yeah. But it was a stressful time. Sure. But sometimes, and I'm sure you've been there, where you pivoted or made a big life change. And I think sometimes those being not afraid to take a risk and make a life change can really benefit you.
Yeah, you sleep well now?
Yes, like a baby.
My life change was joining the academy, right? Leaving administrative healthcare to serve you all. So same thing.
Are you sleeping?
Oh, I sleep like a baby too. Nothing brings me down. Do not disturb on my phone. I'm good. Real quick, we're going to have some fun. Were you in Boston during any of the championships? Red Sox, Patriots, Celtics. Which one did you get to be there for?
Okay, so a little background about me. I went to Boston College undergrad.
Ah, cool.
And actually lived
What
there.
What years?
I graduated Boston College in '92. I was a finance major. I was school of management.
All right.
Boston
I was
College.
at BU from 93 to 2000.
There you go. BU and BC don't like each other.
No, you were further along the
I
T
can't
line.
use the phrase that.
Yeah, no, it's okay.
It's
Yeah,
not appropriate for the
But we're good.
podcast.
Yeah. So you were a Boston guy.
Yeah, and so I grew up in Western New York.
Yeah.
So they have a football team and a hockey team in Western New York. I'm a big Bills fan, but I didn't have a baseball team, and I didn't ever like the Yankees. So even in high school, I loved the Red Sox.
Nice.
And when I was a student at Boston College, the Red Sox were not good.
Yeah, easy to get.
And we could just go and scout tickets. And so I was a diehard Red Sox fan, even when I went back for my fellowship. So the answer is the year that I finished fellowship, they won their second World Series in 2007.
Yeah. What'd you do?
Those were the Papelbon, Dustin Pedroia era.
Yeah. What did you do when they won?
Well, I was at home because I had just started working for Hopkins. But
you were,
But I celebrated.
Yeah. I was there when they won the first one. We were in Brookline, 3 a.m, extra innings. I got
Did anybody sleep in Boston for the entire playoffs?
So I walked to Fenway, and my wife said, "What are you doing?" I said, "You don't have no idea. We've waited forever for this." So my son, we call him Big Poppy.
Oh,
you know what that means?
yes.
Doug, thank you very much. This was awesome, well received. You're very well respected in our community and nationally. Thank you very much.
Thanks, Rahul. Thanks for having me.
Thank you.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.